This podcast is for general informational, educational purposes only and is not to be considered medical advice for any particular patient. Clinicians must rely on their own informed clinical judgments when making recommendations for their patients. All right, welcome everyone to another installment in our Pediatric Hospital Medicine podcast series. This is our 20th episode. Very exciting for us. We're still coming to you from UPMC Children's Hospital of Pittsburgh. My name is still Dr. Tony Tarchichi. I'm a Med-Peds trained pediatric hospitalist here in the Paul C. Gaffney Division of Pediatric Hospital Medicine. Just as a friendly reminder, with each of these podcasts, we do offer free CME credit, courtesy of the University of Pittsburgh. So thank you, University of Pittsburgh. To get it, all you have to do is click on the link at the bottom of the podcast description. It goes to University of Pittsburgh site. You put in you get a free login. You put it in. You answer a couple questions that I write for each CME credit, which are not too hard, I hope. And then you get your free CME credit. So that's all because of them. Now, before we get started on what we're doing today and our special guest, I did want to bring up a couple of announcements. One, we are changing the name of the podcast. When I first started it, I made it a very long name, Children's Hospital of Pittsburgh Pediatric Hospital Medicine Podcast Series. Well, that's really long, and when I have to write something down about it, it just takes a long time. So we're changing the name of the podcast to PHM from Pittsburgh. Much shorter, catchy, I think, and I like it. So we're still coming from the Children's Hospital of Pittsburgh. That hasn't changed. Nothing will change, but just a shorter, catchier name. All right. Now, I have to tell you, if you're listening at home, I have been somewhat dreading this episode. If you ask me what area of pediatrics am I the most uncomfortable in, I'm going to tell you it's nephrology and rheumatology. Those are the two areas that I feel I am not as strong as I'd like to be. So today's episode is on rheumatology. I am fortunate enough to have our special guest with us today who has given up her time to be here. I am fortunate enough to have Dr. Elaine Cassidy. Dr. Cassidy is a board-certified pediatric rheumatologist here in the Division of Rheumatology at UPMC Children's Hospital of Pittsburgh. She's an assistant professor of pediatrics at the University of Pittsburgh School of Medicine. She is the Associate Fellowship Program Director in the Division of Rheumatology, and she's the Director of Education for the division. So, Dr. Cassidy, thank you so much for joining us today and for what we're doing.
I'm so happy to be here. Thanks for inviting me.
Now, before we do anything else, we do have to do our disclosures. So I have nothing to disclose.
I also have nothing to disclose.
Wonderful. So today what we decided to start doing, we're going to discuss inflammatory arthritis. Now, remember, we're getting all this from the American Board of Pediatrics, the Pediatric Hospital Medicine, what they're going to test us on, basically, for the boards. Looking at it, rheumatology is a few things in it. They put Kawasaki's in it, they put lupus in it, and they put inflammatory arthritis in it. So we are going to start with the inflammatory arthritis. We are not going to discuss septic arthritis because we somewhat covered that when we did osteomyelitis, but we'll probably do another episode on that. We are not going to discuss Lyme arthritis because we did discuss that with Dr. Nowak when we talked about Lyme. And we're not going to discuss transient synovitis. So today we are going to talk about what's left in inflammatory arthritis, which is reactive arthritis, acute rheumatic fever, JIA, Juvenile Idiopathic Arthritis, and along with that, we're going to talk about macrophage activation syndrome and HLH, which I will read the full name of it then, but I butcher it, so we'll wait for me to butcher it then. For those of you listening, I'm going to be very honest about this. So whenever I have a patient at the hospital medicine service, and there's elevated inflammatory markers, and I don't know what's going on because none of it makes sense, then I say to myself, I'll bet your rheumatology can be helpful here. I can't be the only one that does that, Elaine. That has to be a regular kind of a consult you get where there's something inflammatory here and it's a little bit odd and I can't quite put my finger on it. Let's call our rheumatology colleagues.
I think, in fact, Tony, that's the most common consult we get. Most of the time it's like, I think there must be something rheumatologic, let's call rheumatology. So we're very, very happy to help in these mystery cases. But one of the things that made me most excited to come and share my experience with you today is because I know that rheumatology tends to be a mystery for most people who are not rheumatologists. So if I can help people understand rheumatology better and know when to think about rheumatology and get help, that's what I That's what I love to do.
That sounds great. And I can tell you, I'm looking at all my research for this podcast, and it's not small. So let's just define arthritis. Let's come up with a definition that we all agree on. So what I have, and I got this from Pediatrics in Review 2011, November 2011, an article called Arthritis in Children and Adolescents by Dr. Janice Chand and Latham Chandram. Again, if I butcher anyone's name, and if you happen to be listening, I do apologize. It's not purposeful. I simply don't know how to do it correctly. And the definition they had was inflammation of a joint can affect one or more joints and is accompanied by swelling, redness, tenderness, warmth, and pain with movement. Would you agree with that?
I totally agree with that, and I think that's very important because most people don't differentiate arthralgia from arthritis. And your differential and your consideration for what to do next or what tests to do is very, very important. Arthritis is very different than just arthralgia.
Now, arthralgia, from what I know, is just pain in a joint. My knee hurts, but it's not red, it's not tender, it's not swollen, it just hurts.
That is totally correct, and that's often missed. So we'll get called, for example, from the ER, and they'll say a kid has arthritis of 2 joints. And so I'll often ask, is it really arthritis? And they'll be like, oh yeah, it hurts. That's not arthritis. You need more for that.
All right, and then further defining arthritis, which again, I had forgotten about this. They go into different types. So there's monoarthritis, which is one joint inflammation. Mm-hmm. There's oligoarthritis, which is joint arthritis involving fewer than 5 joints. Then there's polyarthritis, which is 5 or more joints with inflammation. Mm-hmm.
So those are usually mostly associated with when we're differentiating different subtypes of juvenile idiopathic arthritis, or JIA. Mm-hmm. We use the term oligo and polyarticular to help separate them so we can get more homogeneous patterns. However, it's fine to say monoarticular for one and everything else, essentially.
Okay. Now, here's a question I have. So if you have a patient with joint pain, but elevated inflammatory markers, that's still arthralgia. That's not arthritis until you have the redness, swelling, and inflammation. Is that right?
Yes. So unfortunately, there's no black and white rheumatology. So sometimes arthritis is quite subtle. It's easier to see if there's a large effusion or fluid inside the joint space, but some people have more tenosynovitis or even enthesitis, and that's still in the auspices of arthritis. So enthesitis is inflammation at insertion sites and tendons, and we'll talk more about that, I think, later as we talk about different types of juvenile arthritis and even reactive arthritis.
Okay. All right, good. So now, when in this article, they begin talking about what you would do if you think you have an arthritis in children and adolescents. And they really go into the H&P at first because it's well known that a really good H&P is important to help diagnose this. Mm-hmm. Sometimes they talk about look for viruses that have occurred recently. They talk about common links in the history like fever, rash, other constitutional symptoms, immunization status, family history of autoimmune disorders, toxic ill-appearing child, concurrent URI for like toxic synovitis, sexually active patient for reactive arthritis, knowing local differences in terms of like southwestern Pennsylvania. There's a really high Lyme arthritis now versus I think if you're in Colorado or something, maybe less. And that makes a lot of sense.
I think the reason to focus on that point is super important because unfortunately in rheumatology we do not have a lot of confirmatory testing. So seriously, the basis of all rheumatic diagnosis is a thorough history, thinking about everything from pattern of symptoms, associated symptoms, as well as past medical history, family history. And then exam is important as well. You need a full exam. So if a child comes in and says, my knee hurts, you need to look at every joint because sometimes arthritis doesn't cause a lot of pain and it'll be missed. And knowing if it's polyarticular or monoarticular is super important in association with differential and evaluation that you might undertake.
And sometimes that history of the other joint swelling or tenderness is in the past. So in the past 3 months ago, his elbow was swollen. And so you really have to go back and really drill down on the history for this.
Very, very true. Yes, because the diagnosis of juvenile arthritis requires evidence of arthritis over time. Yeah. So if you've only had this knee pain for 2 days, but 3 months ago you had 6 weeks of elbow swelling, then that would strengthen a case for something rheumatologic instead of just a post-infectious.
So why don't we start with talking about reactive arthritis? And then again, this from the same article, so I want to read what I have so far. The other article we used for this part, so there's another article in Peds in Review in May of 2017 called Juvenile Idiopathic Arthritis, Changing Terms, Changing Treatments by Susan Shenoy, I believe is her name. So we're going to reference that once we get to JIA. But so far for reactive arthritis, we're going to talk about that a little bit. So that's a type of arthritis associated with an infection at a distant site. It is more common in adults, so 3-to-1 male predominance. And then pathogenesis is poorly understood. It's commonly associated with sexually transmitted infections like chlamydia trachomatis, not Neisseria gonorrhea. But it can also be associated with other GI, URI pathogens like Shigella, Salmonella, Yersinia, Campylobacter, Strep pyogenes, Neisseria meningitidis. They talk about this HLA-B27. People who have that, specifically male patients, are more likely to have a severe disease of reactive arthritis. And then clinically, a patient who presents with reactive arthritis will present with mono or oligoarthritis, so again, under the 5 joints. And it's frequently accompanied by other musculoskeletal inflammatory changes. There may be ophthalmologic changes, dermatologic or GU. And then they kind of remind us of Reiter's syndrome, which I remember studying in medical school. Can't see, can't pee, can't climb a tree.
Correct, yes.
So that's arthritis, urethritis, and bilateral mucopurulent conjunctivitis. Mm-hmm. And then they talk about other manifestations of pain, like enthesitis, dactylitis, urinary symptoms, urethral discharge, and then systemic symptoms which can accompany, like arthralgia, fever, weight loss, malaise. I don't remember ever seeing this in a kid.
So the classic form of reactive arthritis, what they're describing in this article, is actually pretty rare in pediatric rheumatology. It's going to be less than 4% of patients we see because, for example, most of the children we see aren't sexually active, which is one of the more common organisms that can cause reactive arthritis.
Yeah.
And even within GI infections, not every salmonella is going to cause arthritis. It has to be arthritogenic salmonella. So you might have outbreaks. It might be the region we're in. So even within a subtype of GI infections, it's a small proportion that will actually have arthritis. So reactive arthritis is important to recognize because they do have multi-system features and they can be quite sick. So treatment by treating the offending organism as well as managing the arthritis and the extra articular manifestations is super important. But even more common than this is what we call post-infectious arthritis, which is still a reactive arthritis, but not this one that's categorized under the Reiter's reactive arthritis.
Yeah, because so they don't really differentiate that. So post-infectious arthritis we'll get to.
Mm-hmm.
A couple questions I have for this. So if you have a sick patient and you've diagnosed them with reactive arthritis secondary to Salmonella or Shigella, mm-hmm. is this a reason to treat the Salmonella or Shigella if they're quite ill from the reactive arthritis? They have fever, they have lethargy, they can't walk, their knees swollen. Mm-hmm. Would you then recommend treating the underlying Salmonella or Shigella?
I think if there's any evidence of ongoing infection, then yes, because that's going to just be a trigger for continued arthritis. But sometimes it happens so far after that it's really a post-infectious process and that infection is over.
And they really talk about to diagnose this. It's a multitude of pathogens can do it. There's no single gold standard diagnostic test. Mm-hmm. So you get a good history. You figure out this may be it. They recommend ESR, CRP, cervical and urethral cultures for chlamydia. That's the most common mm-hmm. cause. And then you just use all that to say, I think this is reactive arthritis. Is that right?
That's correct. It's also the pattern. So they mentioned that it was oligo-articular. So it tends to be asymmetric lower extremity. You can't even have axial involvement with sacroiliitis. Okay. And the point of the HLA-B27 was made as well. So these people tend to be more in the spondylo group. So the adult medicine people call it spondyloarthropathy, where in pediatrics we kind of have a different term that we'll speak about later in the nomenclature of JIA, but they tend to be people who have family history of ankylosing spondylitis or spondyloarthropathies or chronic uveitis, and they tend to have more severe arthritis and sometimes even need more than just a transient treatment with non-steroidals.
And so speaking of that, so then what they mentioned is the treatment is normally just supportive primarily. If there's chlamydia, you treat that. Mm-hmm. But you give NSAIDs, local cold treatments, mm-hmm. avoidance of overuse of the affected joint. They talk about it's really unclear if it's a GI bug, if you get benefit, but if they're sick, it makes sense if they're quite ill to mm-hmm. treat them, and because it could be causing it. And that's what you would normally do for the few kids you see with this.
Yes.
Now, can we talk about, so it's not reactive arthritis. When you have arthritis, just secondary to a virus. Kid mm-hmm. gets whatever, enterovirus specifically, mm-hmm. or adeno, and they may get an arthritis. That's not reactive arthritis. It
technically is, but that's not how it's been defined. So we call those secondary to viruses or other forms of bacteria. We call them post-infectious arthritis. So it's different than septic arthritis because the offending agent isn't in the joint causing destruction like in a septic arthritis. And it is essentially reactive arthritis, but the world has decided in the late 80s and 90s that reactive arthritis is secondary to these few agents and has this similar pattern of like the spondy group and is treated with NSAIDs.
And it's still the same antibodies created to fight off the virus, then cross-react and cause this arthritis in whatever joint it is. Mm-hmm. Treatment's still supportive.
Correct.
And I'm assuming do you often get less toxic appearing patients? Because apparently the reactive arthritis, the kids can be quite sick.
I think that's true, although some, like parvovirus, can be very, very challenging because we sometimes are even worried about other autoimmune diseases until you determine they have actual parvo. Mycoplasma can cause a pretty significant systemic inflammatory syndrome where they get rash and arthritis and fever, so rheum's often involved, and then we find out, they have mycoplasma, and that makes us reassured that it's not something like lupus or JIA. So they can be very sick, but they also can be... I had a head cold 4 days ago. My knees hurt for 3 days, went to the ER, and then saw rheumatology.
That makes sense. And when these kids are admitted, where they have these arthritis, they had something in the past, is it helpful to have infectious disease involved to come up with a slew of possible things we can test for that can help narrow down what may be the trigger? I mean, is it helpful to know that mycoplasma, she had a recent infection or is currently infected mycoplasma? This is probably an inflammatory arthritis secondary to that.
I think it is, especially if they're systemically ill. Because if they're systemically ill, we're going to be thinking about vasculitis, lupus, autoinflammatory syndromes, and if we can rule out infection or rule it in, that would help us with treatment.
One way or another.
Yeah.
Okay. So now the next thing we have, after we do this, we're going to go to our bad joke segment. So the next thing we have is acute rheumatic fever, which I'm going to be very honest, I can't tell you that I've ever actually seen. Am I alone in this? How often have you seen acute rheumatic fever?
So I've only seen it 2 or 3 times in about 10 years.
Okay.
So that tells you how well we prevent it here, at least in this region. But also I think sometimes it can be pretty mild and can be missed. So 2 of the children I met actually were, in retrospect, they had prolonged joint pain and met me, and then I heard a murmur in an outpatient setting. And then we echoed them and we did some labs and we found out that, in fact, they had acute rheumatic fever.
So, okay. So then going into it from that same article is an inflammatory process involving many organ systems caused by group A strep pharyngitis. In the U.S., the incidence has declined, but we still get some local outbreaks. And they still diagnosed clinically by the Jones criteria. So the Jones criteria was split up in the major and minor criteria. The major criteria is polyarthritis involving large joints, non-deforming.
And migratory.
Migratory.
That's important.
And for those of you listening at home, if you want a good place to get pictures, I put a note in my notes here saying in the Atlas of Pediatric Physical Diagnosis, there are some really nice pictures for acute rheumatic fever along with the article. So I know some people like to look at pictures when they get home, but this is a good one. That's a good place to go. Then, of course, some of the other major criteria. So migratory polyarthritis, carditis, subcutaneous nodules, I don't know why I started that, chorea, and erythema marginatum. And then the minor criteria, fever, arthralgia, prolonged PR interval on EKG, an increase in acute phase reactants. You still need 2 major criteria or 1 major and 2 minor criteria to diagnose acute rheumatic fever. And then they recommend you get confirmation of previous group A strep infection, either by throat culture, rapid strep test, or ASO. And then the treatment is still single dose of benzathine, penicillin G, or 10 days of oral penicillin. And then you have to do antibiotic prophylaxis. And then arthritis and acute rheumatic fever tends to be very sensitive to aspirin. So after you've treated these kids, do you give them aspirin?
We usually stick with things like Aleve or naproxen.
Okay.
We get the same benefit as you would with aspirin, with less of the potential side effects reported in the past with aspirin use.
And so this is something we still have to know. We're seeing a lot less of because we're so aggressively diagnosing strep and treating it with amoxicillin early on in the U.S. Is that right?
I think that's true. And the big thing is we still have to think about this. And there's a lot of times we get consulted and think about it, but rare that we actually make a diagnosis. But, kids get strep a lot. So that, whenever we hear of arthritis in the setting of strep, it's definitely something to think about because the long-term consequences of carditis, with valve dysfunction are super important to catch.
And then you still send everything they talk about, the ASO, throat culture, rapid strep test.
Right, and we usually will also do the anti-DNA speed because you increase your sensitivity if you have ASO and anti-DNA speed.
Why is that?
So some kids don't mount antibodies to both things. So if you send both, you're going to have better catch.
So if you have a negative ASO but a positive anti-DNA speed, then you'll say, okay, this is evidence of a previous strep infection. We have acute rheumatic fever.
In the right circumstance. The hard part is our bodies, sometimes when we're mounting a host response against multiple infections, will also make antibodies to other things because we're not, concentrated on the organism we have. So many school-age kids will have an elevated ASO or anti-DNA speed. So it's really important to only send it when you have a history or a concern for a strep infection leading to problems.
Okay. So I don't have much more on that. And you said you've seen 2 cases in the past 10 years, and you're a subspecialist at a tertiary care referral center.
It's not very common. What we do see more commonly is post-strep reactive arthritis.
Is that right?
So I think that's important to touch on because I think it gets missed sometimes too. So post-strep reactive arthritis is when you have arthritis within 7 to 10 days of a strep throat infection. And it's very similar in that it causes arthritis, but it's very different in the time frame of onset, the lack of other features, the lack of fever, the lack of significantly elevated inflammatory markers. And the arthritis is slightly different. Instead of migratory, it tends to be more persistent and unresponsive to NSAIDs.
So then how long after strep would you get a post-strep reactive arthritis?
Very quickly. So usually like 7 to 10 days.
Okay. And then you, of course, wouldn't meet Jones criteria, but you have this arthritis, you have this history of strep infection. So what do you treat the strep and then it gets better?
So it takes 4 or 6 weeks to get better, even treating the strep.
Wow. So they're out for 4 to 6 weeks.
Yes, and it's very painful for many kids. So we like to do a couple other things in this setting because you want to make sure it's not rheumatic fever that's just mild. So we always echo these kids to make sure they do not have carditis.
Okay.
And we treat them with 1 year of antibiotic prophylaxis to help prevent recurrent strep infections so that potentially would not go on to develop carditis or other associated features.
Okay. So now if I'm a hospitalist in a smaller community hospital and I don't have a pediatric rheumatologist, and I think I have either reactive arthritis that's not very ill, just someone who has salmonella as an arthritis, we treat the salmonella, the reactive arthritis is improving and they're able to walk, or a milder post-strep reactive arthritis, or even a post-infectious arthritis, when should I say, I'm not going to call the rheumatologist to come see you because we don't have one, an adult rheumatologist, we're not going to bother them, but you need to follow up with the pediatric rheumatologist in Pittsburgh, in Cincinnati, in Philly. We'll make sure you get an appointment as an outpatient. When do you want to see these kids?
So I think it's best if they're doing well and responding to treatment, 4 to 6 weeks.
Okay.
Because before that, other than maybe symptomatic improvement in treatment, we won't be able to say, no, it's alternative diagnosis, no, we missed the boat, because we still don't have other symptoms or signs to make a diagnosis of juvenile arthritis or lupus unless things change and they get more symptoms or get worse.
Okay.
So that's why it's also hard if a child presents to an ER with what looks like arthritis in a joint or two. If they've only had it for a week, there's not a lot that a rheumatologist is going to add. If an ER primary care hospitalist is educated and feels comfortable saying, yes, this is arthritis, I made a pretty good history and physical, we're going to treat it with nonsteroidals and then have them follow up. Because before 6 weeks, we're really not be able to differentiate anything from a post-infectious.
Because it could go away in that time and then nothing happens and you don't make any criteria for anything.
Correct.
Okay.
So the only other time I think that it's important to see this is if the family's particularly anxious. We're happy to meet them and, talk to them. But some families are comfortable. Yes, this is arthritis, it might go away. Yeah. And they don't really need to drive 4 hours to see us. But there are families who need answers, want to hear about everything possible, and then it's fine for us to see them.
And now we have a big Amish population here. What do you do with those kids when it may be hard for them to come in, or patients who for some reason socioeconomically it's hard to get back and forth wherever to get to see you? Would you want to be consulted to them, maybe phone call kind of a thing?
Mm-hmm. So, we're always certainly happy to talk about things and answer. I sometimes make people have a hard time or drive 4 more hours just come at 8 weeks or 10 weeks because then we really are pretty sure if there's still persistent arthritis that it wasn't like a post-infectious arthritis.
So then at that point, you'll know one way or another. So
Yes.
to make it more bang for their buck, I guess.
Exactly.
Way to say it. All right. I promised the bad joke segment. Here we go.
Okay.
I'll do the first one. You want to do the second one?
Sure.
All right. Elaine, did you hear about the race between the lettuce and the tomato?
No.
The lettuce was ahead, and the tomato was trying to catch up.
Oh, very good.
I really do love these. All right, you're up.
Why did the belt get arrested?
I don't know.
He held up a pair of pants.
That's great. This is the medical one. What did the femur say to the patella?
What?
I need you.
All
right. Now we're going to get to where we're going to spend the bulk of our time, which is going to be JIA. Now I have to tell you, I'm med Peds trained, so when I first started studying for this, I guess for my board, I was like, it was called Juvenile Rheumatoid Arthritis. I was like, oh, I got that from the adult side. I'm okay. And I think I've completely stopped studying this. Because when I was sitting here reading this, I was like, some of this was new, and some of this I didn't know. And I spent a lot of time reading about JIA. It's not the easiest topic, so I'm very glad you're here. So apparently, it's also known as, this used to be known as juvenile rheumatoid arthritis. Now we do not call it that anymore. And it's a wide spectrum of arthritis that occur before the age of 16 and have to last longer than 6 weeks. And they don't fill the diagnostic criteria of other known entities. So it can't be something else. It has to be, doesn't fill anything else. The kid's less than 16 years old and has to last longer than 6 weeks. And this is the most common pediatric rheumatologic disease.
I think so. We quote often 1 in 1,000 kids. So it's probably the most common thing to see.
That's amazing. And then they think in terms of what causes, there's both genetic and environmental components that are implicated. For pathogenesis, the new research reveals that there's some innate immunity, specifically neutrophils, playing additional important roles in the disease process. But again, they think it's multifactorial etiology from this article. Now, they talk about the exact incidence for pathogenesis. Is that true, or is there new stuff that I don't know?
No, it's super broad depending on population and where you're looking. For example, people of Northern European descent have higher incidences of JIA than others. So if you're looking in an area in the United States that's quite heterogeneous, then you're going to get a way different incidence and prevalence than you might if you were looking at a really homogeneous population in Scandinavia.
Okay. So then, they talk about the exact incidence being unknown, varied across the world. In the U.S., they mention about 14 in 100,000 kids, or 113. So that's roughly 1 in 1,000. Yeah. Well, that's 1 in 10,000 they say here, but it's a lot. Mm-hmm. Now, there's the International League of Association for Rheumatology criteria, ILAR criteria, which we're going to be referencing a lot. Yes. And then they talk about JIA defined as a chronic arthritis with no known cause, again before the 16th birthday, again at least 6 weeks of symptoms. And now it encompasses actually 7 arthritis. Mm-hmm. And systemic onset JIA, polyarticular rheumatoid factor negative, polyarticular rheumatoid factor positive, oligoarthritis, enthesitis-related arthritis, ERA, psoriatic arthritis, and then undifferentiated. And there's no laboratory test which can really distinguish this from anything else. So this is all history, physical, and you have to really drill deep and decide this is what you think you have.
That's exactly right. That's super important. All you need to diagnose juvenile idiopathic arthritis is be less than 16 when it starts. So you might not meet someone until they're 7 or 18, but if it started before 16, they'd still be classified as juvenile. They have to have arthritis for 6 weeks. That allows you to rule out a lot of those post-infectious arthritis, because you don't want to put somebody who just has arthritis because of a quick viral infection on more intensive treatment. And then not anything else, because like you said, we do not have any lab tests. We don't even really have imaging that definitively confirms it. So you have to be thoughtful and say, oh, I live in Western Pennsylvania. Could this be Lyme? They've also had weight loss and diarrhea. Could this be arthritis because they have Crohn's disease? They've had weight loss, fevers, and weird bruising. Could they have leukemia? So you have to be very thoughtful about what else it could be to definitively say it's not any of those. It is, in fact, juvenile idiopathic arthritis.
And now, along those lines, what I've learned from this, and tell me if I'm on something, if I'm right here, is that parts of the history that are suggestive of JIA, presence of morning stiffness and achiness, for about 15 minutes, and that in toddlers can be described as being grumpy, which my toddler is grumpy in the morning, or a limping child in the morning after they nap. Improvement in stiffness and pain with activity as the day progresses, and nothing else. You didn't give them ibuprofen or anything. Presence of gelling, which I didn't know what that was, which is joint stiffness after prolonged periods of inactivity, which is similar to, but I guess just not sleeping or they're sitting and watching a movie or something. Swelling or decreased range of motion in the joints. Often pain is not the first symptom of JIA, and occasionally arthritis or synovitis can be painless, which I did not know.
Yes, those are all important points because pain can be a part of it, but it's often not severe pain. So whenever we have a kid who has super severe pain, we're often thinking about other things.
Is that right?
So cancer hurts very badly. Rheumatic fever hurts very badly. JIA, most of the time, isn't stopping them from doing things unless, of course, they have 40 joints and can barely make a fist or, pull their pants on. But JIA tends to be quite subtle and insidious. So stiffness is super important. 15 minutes is kind of the lower limit. You usually are going to see 30 minutes or an hour even. And the same thing with the gelling after prolonged rest. It'll be at least 30 minutes or an hour. JIA has stiffness, but other entities will have stiffness too. Some kids who have hypermobility will report stiffness in the morning. So that's why we're looking at that 30 plus minutes
of stiffness. Because now you say, because the patients we've had where they've come in with knee pain or something where we've diagnosed cancer, it's usually with MRI they see something in the bone marrow. But they're in a lot of pain. Mm-hmm. And so JIA is more of an achiness or an insidious onset versus significant, this hurts so much I can't do anything, screaming, pain, child needs morphine or something.
Exactly. And so are there some kids, though, who just pain for them is super intense and they stop? Yes, but that's very rare. It's more common, like I didn't even know I hurt, but the swelling was so big I couldn't put the 2-year-old's pants on. And, oh, by the way, I have had to carry them down the steps in the morning when they used to want to crawl. That's usually what we see.
And so some of the things they talk about in terms of physical exam, what you look for is how a child sits, gets off the table, walks, runs in the hallway. Like you said, examining all the joints, looking for arthritis, because it can be somewhere else you just didn't notice it. That's not what they're complaining about. Correct. And then some of the things which I didn't remember that they can signify chronic arthritis. Presence of muscle weakness or atrophy, bony overgrowth, specifically seen at the knee, you can see that, and a leg length discrepancy.
That's very true, because sometimes, like I said, it doesn't hurt. So they might fall, go to ortho, and ortho's like, your knee's swollen and their different legs, go see room. And so we'll meet someone who thinks they've only had a couple of days or weeks of symptoms, but in fact they already have atrophy and contractures, so we know that the arthritis has been there much longer.
Wow. And then TMJ disease, and you can have arthritis at your TMJ.
That's correct, and it's actually a very important joint to look for because you get dysmorphia of the face. If you have especially chronic or asymmetric arthritis. The jaw joint, if affected by juvenile arthritis, will grow less. And so they'll have an asymmetric face if only one side is affected, or if both sides are affected, they'll have very, very small jaw. And then oral aperture is affected, so kids will have trouble eating or drinking. I've seen some kids who've only been able to open their mouth 1 centimeter.
Oh, geez.
So it's very hard for them to maintain nutrition.
And when you say that's an important thing to look at, you mean physical exam or do you mean also with imaging?
So physical exams are first step, but then imaging is the only way to know. Because if you really look at everybody, some of us do have asymmetric jaws or small jaws.
Sure.
So MRI is the only way to 100% prove it, even in the setting of a known diagnosis of juvenile arthritis.
And will and again, this is an achiness, so the child won't complain of pain there, but it'll be more they can't open their mouth very much, or they don't take big bites, or what would you look for?
That is correct. They may never complain about pain despite erosive, dangerous, damaging arthritis in the TMJ. So they won't chew more foods that require more chewing, like taffy or steak. Oh. They might just not do that, or they might not want to eat in the morning, but they'll eat better in the afternoon. Okay. So most people aren't measuring oral aperture, but a quick way is a child should be able to fit 3 of their fingers in their mouth. And that tells you that they're pretty okay if they can do that. Oh. So that's a quick way. And you want to look
3 of their fingers in their mouth.
3 of their fingers when their mouth's fully open. And they should also be able to, you can see a symmetry when they open their mouth. You should be able to see that both sides of the mouth are about the same. And when they close their mouth, you should see that the teeth line up in a straight fashion. Sometimes in arthritis, besides the jaw being smaller, one side of the mouth will be smaller when it's open. And when they shut their mouth, the jaw will tilt to one side. Oh. So these are things that if you just start looking on a regular basis, it takes 2 seconds because you're already looking in their mouth for most physical exams. You can really pick up things.
I did not know that. That's great. And now they define, emphasize what you already did, and then uveitis, because it's an important thing to look for in JIA, because it can be associated with several categories, and they're specifically defined as presence of synechia, which is abnormal distortion of the pupillary shape, and inflammation of the eyes is uveitis. And that's one of the things you really worry about from what they're describing.
Right. So uveitis, there's 2 major subtypes of uveitis in the whole family of juvenile idiopathic arthritis. There's a silent subtype. It happens in kids, more commonly in kids younger than 6, who have oligoarticular or fewer joints, who tend to be female, and who have a positive ANA. We'll talk more about ANA later. But before we recognized that relationship, it was the leading cause of blindness in developed countries. But now that we recognize it, children who fit those criteria will see an ophthalmologist every 3 months for the first 4 years after diagnosis, and then every 6 months for the next 4 years. So if we can catch this before it gets very active, we can treat it and prevent damage. They have no symptoms of uveitis if it's not noted on a physical exam, or by the time they have changes like synechia or cataracts or glaucoma, then you wouldn't know to treat it.
They have no symptoms.
No symptoms at all.
So it's not that they're needing glasses and also there's nothing.
Not one symptom. The eye looks clear, quiet to the naked eye.
Sure.
A child does not report blurred vision. They don't report drainage, itch, sting, and nothing.
So it's just you diagnose JIA, and now you know you're going to send an ophthalmologist for the first every 3 months for the first 4.
If they meet those younger kids. Younger kids. So under 6 at onset of arthritis, females, but males can get it too, and fewer joints. So oligoarticular, psoriatic are more common, although RF negative polyarticular also get the uveitis sometimes. There is a second type of acute uveitis that's more common in the enthesitis-related group or the spondyloarthropathy group, where it's a bright red eye, blurred vision, hurts, they're photosensitive, and that's much what the adults would see in disorders like ankylosing spondylitis. And then to get to the eye doctor, and again, it's treatable. So we really are very, very sticklers about getting the younger kids to the ophthalmologist. Okay.
Now, let's talk about the diagnostic criteria, and then we can get into our discussion about what labs, because that's a big issue. As before I came to Pittsburgh as a hospitalist, one of the things I would do is just order all these labs. So we're going to talk about that. So for systemic JIA, which I think where we're going to go from here, that's a unique form of JIA, used to be known as systemic onset juvenile rheumatoid arthritis. The clinical presentation is daily or quotidian, which, again, you probably know this as a rheumatologist. I didn't know what that word meant. I had to look that up. And that just means daily, which I found to be odd that they did it twice. But quotidian, daily, intermittent fever can be as high as 102 to 104, with or without the classic evanescent salmon pink transient rash, macular rash. And then other features of JA include lymphadenopathy, hepatosplenomegaly, serositis, such as pericarditis, pleuritis, or peritonitis. And the ILR definition diagnosis is arthritis and fever for greater than 2 weeks, documented quotidian 3 times a day fever, plus 1 or more of the things we just mentioned, evanescent rash, generalized lymphadenopathy, hepatosplenomegaly, or serositis. Go ahead.
And the difference about this one is that it has systemic features. Kids can be quite ill, and you only need to have symptoms for 2 weeks. Other forms of juvenile arthritis need to be 6 weeks or longer. So that's an important point. These kids can be diagnosed much sooner.
And the differential for this, from what they talk about, I can see why Kawasaki's are being differential, because you have fever for a long period of time. One of the things people are going to think about is Kawasaki's. So if I have a patient I'm trying to rule out that they have 7, 8, 9, 10 days of fever, that's not exactly 2 weeks. And if they have arthritis, and they're going to probably meet at least atypical Kawasaki's. They have the fever. If they have a rash, now if it's a salmon-colored pink evanescent rash, that's great. But the rash isn't always like that. Is that true?
It's true, but most of the time, what helps me think about systemic and Kawasaki's differently is the rash and systemic comes and go. So they're totally pretty fine except for arthritis. Okay. And then around 5 in the evening, they'll get this high fever. The rash will pop up. They look very unwell.
Right.
And then again, they're better.
Because the kids in Kawasaki's are miserable.
Miserable, and fever's really persistent.
Okay.
You shouldn't have mucocutaneous changes as much like you would see in Kawasaki's, although if you have a kid who's not drinking because they have febrile and arthritis, they might also get dry cracked lips. Yeah. And labs can be very similar, unfortunately, because they'll have elevated white count, they'll have anemia, elevated platelets. They may have transaminitis in systemic, so you're not going to get a lot of help from labs in differentiating those two. And the hard part about systemic, any age. It can be a young child all the way through an adult. In the adult world, it's called stills.
And you can have arthritis with Kawasaki's and it not be systemic onset JIA.
That's correct.
So if I'm a hospitalist and I'm seeing a patient, I'm ruling out Kawasaki's and there's an obvious arthritis there, and I'm near that 2-week range, I may give you all a call just to say, of course I'm going to go down my pathway and I may end up getting an echo, and if the echo is negative, which would be very reassuring, but before I give IVIG. Now, is there any, assuming we're not sure, is there any harm to giving IVIG for a patient with systemic onset JIA?
No harm at all.
Okay, so then we'll probably end up just treating it that way.
I think it's totally reasonable if it is that much overlap. There is actually some literature that talks about the overlaps. Because there are some kids who you really can't tell, so you treat them for Kawasaki's because that's going to be the more life-limiting.
Right. And you see what happens.
Yes, and then you watch them over time.
Okay. I mean, that sounds very reasonable because that's exactly what I would be thinking to do. Now, again, this article we talked about the Peds in Review in 2017 on juvenile idiopathic arthritis, changing times, changing terms, changing treatments. It has an excellent table, and I'm going to tell you exactly which table it is. Because the people who did it, I think, really thought about someone like me who's not very comfortable with rheumatology in general. Table 1. Should have got that easier. Categories of juvenile idiopathic arthritis. It goes through the ILAR categories as to what the specific disease is, the previous nomenclature, and then the definition. And so some of these are very straightforward. The polyarticular RF negative and RF positive is just arthritis greater than or equal to 5 joints during the first 6 months, again, poly, more than 5, or equal to 5. Of disease, and has to be 6 months, and then RF negative or RF positive.
So, I think we developed those subtypes to help understand a more homogeneous group, to know what you need to worry about for them. For example, the oligoarticular is more common to have the silent uveitis. The enthesitis related may have more worries about eventually developing inflammatory bowel disease or getting ankylosing spondylitis. So they're imperfect in some ways because some kids will cross categories. Okay. Some kids end up having to be in the undifferentiated category. For one of the rules of this nomenclature is that if you have a positive rheumatoid factor, you're not allowed to be in another category. Okay. So sometimes your mom and dad both have uveitis and ankylosing spondylitis, but you have a rheumatoid factor. So you're not allowed to be in the enthesitis related or the rheumatoid factor poly technically. Okay. So we have to call you undifferentiated. So it's imperfect, but most of the time it helps us understand and think about treatment. So the takeaway points for juvenile arthritis are, when do I think about it? Mm-hmm. That's talking about the stiffness, the insidious onset, the swelling, maybe noticing bony overgrowth or muscle atrophy. What do I have to do? Rheumatologist is helpful. Yes. Ophthalmologist is super important too. I don't necessarily expect a hospitalist or a PCP to know what subtype their patient belongs to when they meet them. But having recognized them so that when you are following up on these patients, you understand what that means and what you have to worry about, I think is more important. Just to notice there's multiple types and your patient might be under a different subtype, and noticing, like, for example, rheumatoid positive poly is a much more aggressive arthritis. Oh. It's very similar to what the adults deal with in rheumatoid arthritis. Okay. So we're going to be very aggressive up front because we don't want them to have joint destruction. Our goals in treatment of juvenile arthritis are obviously to prevent pain and allow full function of a joint, but these children have to grow normally. Arthritis impedes growth or causes more growth in the joint, which will lead to asymmetry of the legs, which can lead to then mechanical pain. So we have to think about normal growth in addition to just dealing with pain. And we want these kids to have normal joints for 100 years. And so the sooner we can get the arthritis under control, the better they do.
So now, if I'm in a place, well, not, let's say, our hospital, but a place where there is a community hospital, pediatric hospitals, or I just don't have a pediatric rheumatologist at my university hospital, and I have a kid, I think this is juvenile idiopathic arthritis, meeting the criteria, there's the right setup in history and physical. Is this someone I should transfer, do you think, or is this someone I should call, whoever the nearest pediatric rheumatologist is, tell them the story, and see what they want to do. Whether they say, I'll come to you, I'll get emergency privileges or whatever, versus discharge them, send them to my hospital, versus discharge them, send them to my office. I can see them in the office tomorrow or something.
Right. So most of the time, excluding systemic, it is not a life-threatening or even hospital requiring diagnosis. It's usually managed as an outpatient very well, especially because most of the time they're admitted because they're worried about a septic joint or something more intense, like a malignancy, for example, if they have weight loss as well. But once we get to the diagnosis of juvenile arthritis, it's very, very treatable as an outpatient. And if you have the ability to discuss with the rheumatologist, you can get treatment initiated and any potential tests that need to be to help confirm the diagnosis completed, so they don't have to emergently go 4 hours to the next day. But I do think a rheumatologist has to be involved. Some places might not have pediatric ones, but they have adult ones who are willing to help out too, just because the exam of arthritis, it can be missed if that's not what you do all the time every day, because some arthritis can be quite subtle, and it really helps knowing outcomes in future, how many joints are involved and how things change over time.
Okay. And one of the things they talked about is children who have systemic onset JIA, they must undergo complete infectious and malignancy evaluations when they're diagnosed, including serology, cultures, even bone marrow examination before you can say for certain systemic onset JIA, because the symptoms can be so similar to what you may see in a cancer or something. Is that right?
That's correct. So not every child will get every test.
Mm-hmm.
It really depends on what they look like, what the symptoms are. So some kids have prominent lymphadenopathy, might not have as much arthritis, and then have really unusual labs. They're probably going to earn themselves a bone marrow.
Mm-hmm.
But if there's a child who really doesn't have that much lymphadenopathy, but totally has pericarditis, has arthritis, has had the fevers, has a classic rash, labs are really very consistent, and it's gone on long enough, we probably wouldn't bone marrow them, and we might not send a lot of infectious disease studies.
Now let's talk about labs, because what we can send and what we should send are not the same thing.
That is correct. That's very correct. So I think the big message for rheumatic diseases is they're system-wide diseases. So understanding what you're dealing with is the most important thing from the lab. So what we need are basic labs. A comprehensive chemistry really gives us a lot of information. It lets us know about inflammation, chronic or acute, with like things like albumin. It lets us know that renal function and liver function is normal. We need a CBC. It tells us so much. It lets us know if they're anemic and what kind of anemia they may have, what their platelets are doing. For example, in systemic, we would expect the platelets to be very high. In something like lupus, platelets would be very low. So it tells us so much just from a white count. Differential is important too. Inflammatory markers. We like an ESR and a CRP because it tells us about acuity and chronicity. So some rheumatic diseases, the sed rate will be quite high, but the CRP is totally normal. So it helps us look about, is there infection too? And someone we already know may have something and comes in with a fever. If their CRP bumps, but their sed rate's about the same, it might be just an acute infection on top of their already chronic autoimmune disease.
Is procalcitonin at all becoming more helpful for this, for your people?
We have not been using it.
Okay.
So I can't comment on the world in general. There might be some people using it, we haven't been.
Okay.
We also like a urine because we're always looking for a renal involvement to help us go in one direction or another. And then everything else after that is considered secondary testing for a rheumatologist. And it's guided by what your differential is. So we just mentioned in the discussion of juvenile idiopathic arthritis, there is no lab test. We do eventually send labs if we already know you have juvenile arthritis, just to stratify you or help put you in a category. Those labs include the ANA, the rheumatoid factor, and the HLA-B27 gene. However, those tests are not useful screening tests. And unfortunately, what we see a lot is people use them as screening tests. They'll hear that a child has some joint pain or fatigue, and they'll send all those labs without really narrowing it down to that we're pretty sure this is something like juvenile arthritis. For example, rheumatoid factor. Less than 10% of all kids who have juvenile idiopathic arthritis will have a rheumatoid factor. And a rheumatoid factor can be positive if you have infection, malignancy, or other autoimmune diseases. So it does not do anything for diagnosis. It's just helpful if I already have a diagnosis and I'm looking for factors about that child.
Okay.
Same with ANA. It's positive in many, many healthy kids. It's also positive if you have an infection, if you have malignancy, if you have autoimmune hepatitis, if you have a cancer. And it's one of the most common reasons kids drive to see a rheumatologist. And so they Google the ANA, and then everyone's upset, and we end up telling them you're probably okay. So it really shouldn't be sent unless you're really, really sure you already know that you have a child with juvenile idiopathic arthritis and you're trying to look at risk of uveitis in a young child, or you're really pretty sure you have something like lupus going on.
So, okay, that makes sense, because that's what I read about that. ANA, if positive in a kid with JIA, increases your risk of you having uveitis. So that's a kid you'd be for sure certain to send to an ophthalmologist.
Right. So in regards to that, even if I didn't have any labs, if I met a young kid, I would tell a PCP who has a young kid under 6, especially if they're really young, 4, 3, 2, to get to the ophthalmologist, even if you can't get to a rheumatologist as soon as you can. Because uveitis can actually precede the onset of joint pain.
Oh.
And it can be quite damaging. So
if I'm stratifying, I have to send my kid, I'm in a community hospital, and I send them to 2 places when I discharge them. I'm doing ophthalmology first, then rheumatology. If they're systemically ill and very sick, which you can be with systemic JA, which we're going to talk about, I guess, shortly, then I can transfer them if they need to go to PICU kind of thing.
Right. And then the systemics actually don't get uveitis. So they have so many other problems, but they don't have to worry about eye doctor as much.
Now, I looked, so one of the things they talked about for systemic JIA is the fact that kids can have this macrophage activation syndrome. And I have to tell you, almost nothing has given me a bigger headache to try to differentiate macrophage activation syndrome from HLH, or, let me say the name of HLH correctly because I always butcher it. Hemophagocytic lymphohistiocytosis. I think I did that.
Yeah, you did great.
So the 2 articles I looked at for this were the 2016 classification criteria for macrophage activation syndrome, complicating juvenile idiopathic arthritis. This was in the Annals of Rheumatologic Disease in 2016 by Angelo Cavelli et al. There was a whole large group of international rheumatologists that went about doing this. Now, this was interesting because this syndrome seems like it really is not easy to diagnose. What they did was take, each of them brought from all over the world, like over 1,000 cases that they thought were macrophage activation syndrome. And then a group of them got together and examined each and every case and came down with a smaller list that just said these are probably macrophage activation, which means if you take 2 pediatric rheumatologists from anywhere and present them with 2 patients, they may not agree that it's macrophage activation syndrome because it's challenging to diagnose. And in fact, there was a letter to the editor in Pediatrics in 2004 where they had a case on a previous article where they diagnosed with macrophage activation syndrome, and they actually, this rheumatologist Nicholas Andre, Dr. Nicholas Andre and Dr. Bertrand, Rocalare, wrote and said, we actually don't think that's what this was. This was something different. So it's a challenging thing to diagnose.
It's super challenging to diagnose, and there's so much at risk because morbidity and mortality, when you add consideration of macrophage activation to systemic JIA, is very, 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 very clear and real. So the hard part is HLH is even hard to diagnose sometimes. And then MAS is thought of as a secondary form of HLH in the setting of rheumatic diseases. And then to make it even harder, some children, their first or initial manifestation of systemic JIA, lupus, can be macrophage activation syndrome. So then that complicates the picture. Macrophage activation syndrome and HLH can present as what looks like shock or sepsis. And so, what's more common? Infection. Yeah. So true sepsis. So you're going to go down that infectious pathway, and then the child is really, really sick, and it's hard to stop the whole process.
So now, talking about what it is, it's a term we describe to describe a potentially life-threatening complication of systemic inflammatory disorder, specifically systemic JIA, or the adult equivalent Still's disease. They said it can occur in other things, specifically Kawasaki's and certain oncologies.
And infections.
And then it's an overwhelming inflammatory reaction due to uncontrolled and dysfunctional immune response involving the continual activation and expansion of T lymphocytes and macrophages, which cause massive hypersecretion of pro-inflammatory cytokines. The clinical features: high non-remitting fevers, hepatosplenomegaly, generalized lymphadenopathy, can be CNS dysfunction, and hemorrhagic manifestations. Classically, they talk about these kids have abnormal bleeding, abnormal cardiac liver, they have cardiac, liver, and renal failure. So they're quite ill. Your lab abnormalities are pancytopenia, increase in ferritin, increased liver enzymes, increased LDH, increased triglycerides, increased D-dimers, increased soluble interleukin-2 receptor alpha, aka CD25, and decreased fibrinogen. Your histopathology is you get this accumulation of well-differentiated macrophages exhibiting hemophagocytic activity in the bone marrow biopsies. I'm assuming this happens a lot because they don't know what's wrong with these kids. And then among patients with JIA, estimated it's about 10% will get or have macrophage activation syndrome. And they think it may be there may be a subclinical MAS that occurs in even a higher, like 30 to 40% of kids. And then it can cause death, and the mortality rate's approximately, they say, 8%, although that's different looking at what I've read. Each article gives a little bit of a different number, but it's not small.
It's not small. It's definitely real. I think outcomes have been better because there has been more discussion. So it's higher on people's differential, just like Kawasaki's. Every PCP, every hospitalist always has Kawasaki's in the back of their mind because you don't want to miss that. And I think MAS is on a lot of our minds, especially if we already know a child has something like systemic or lupus or Kawasaki's.
And they, in this article, came up with clinical criteria. And again, there aren't any specific tests that say, oh, this is definitely macro. And there's no classic multi-center prospective randomized controlled trials for this. So this is all expert opinion. But this was with like everyone in the country, in the world, who's an expert on this got together to come up with the criteria. Their criteria, they said sensitivity of 0.73, specificity of 0.99, which is pretty good, positive predictive value of 97.4%, and negative predictive value of 85.9%. The area under the curve was 0.86. They did pretty well. And what they said is for a febrile patient with a known or suspected JIA as having macrophage activation, this article was focused on that, ferritin of greater than 684, and any of the two following, platelets less than 181, AST greater than 48, triglycerides more than 156, or fibrinogen less than 360.
And the thing to pay attention to, this is talking about MAS specifically. So HLH has different criteria. And the MAS criteria are less strict than the HLH criteria. For example, the cytopenias are much lower in HLH than they are in MAS and systemic JIA. So it's important to note that because sometimes, especially if we don't know they have JIA yet, it's their initial presentation. If you ask a hematologist if this is HLH, they're going to say no. But if a rheumatologist is looking and we're worried about systemic, we're going to say yes, it's the same process.
And so now, if you have you've been consulted in the PICU and you think this child has systemic onset JIA, this is the first time we're seeing it, and it's presenting as severe MAS, what are you going to treat with?
So mainstay of therapy is going to be bolus methylprednisolone. We do 30 milligrams per kilogram.
Very high.
Very high. And we would do that at least 3 days, if not 5 days or more. And then after that, there's no one set treatment. So some people have used IVIG with good benefit. IVIG would be great if you're not 100% sure that you're not dealing with an infection that triggered things as well, because you wouldn't have a lot of immunosuppression. We would also use biologics like anakinra, which blocks IL-1 with great success, and we'll use much higher doses than a standard dose. A standard dose is 1 milligram per kilogram. We will do 4 milligrams per kilogram every 6 hours, or even continuous IV infusions. And this has shown great benefit. And then medicines like cyclosporin have been used for a very long time and sometimes can also be of great benefit.
They talk about some of the new biologics may change the mortality of MAS associated with stomach onset JIA, which seems to be what you're saying too.
Right. So we use not only the anakinra, which blocks IL-1, but we've also used Actemra, which also blocks IL-6. So we have a lot more things in our arsenal, and so kids do well.
I think it's good for us as hospitals to really know this a little bit more. That's why I wanted to go over it, because it's something to keep in the back of our mind for as a differential.
One thing about it too, because systemics that are actively flaring or have an infection, when you look at their labs, so a baseline systemic who's active will have very high white blood cells, very high platelets. They'll have a very high sedimentation rate. When you're going into MAS, their cells will fall. So sometimes it's not true cytopenia, but it's a relative cytopenia.
From where they were.
The sed rate should also fall. So if they're very sick and you see their sed rate dropping, that's not good. That doesn't mean you're doing a good job. That means they're probably going into MAS. So I always talk to residents about that. If your CRP is high and the kid's very sick, but their sed rate's normal, that is a bad sign. And you definitely need to think about macrophage activation syndrome.
Oh, wow. And now for HLH, the article used for that is the one you sent me, Review HLH 2004 Diagnostic and Therapeutic Guidelines for Hemophagocytic Lymphohistiocytosis by Jan Ing Henter et al. This is in Pediatric Blood Cancer 2007, issue 48. So now HLH, and that's one of the things, when you said was one of the things I noticed is that if I take a wide angle, if you look at these from far away, they're very similar. Now, MAS is more common in your systemic onset JAA patients. HLH, which we're going to talk about, can occur secondary to certain infections, bacterial, parasitic, viral. Certain viruses like EBV may trigger it as a response to having cancer or even to getting cancer treated. A child can have HLH. And it's comprised, what they talk about here is two different conditions, primary and secondary form. Now, primary is autosomal recessive familial hemophagocytic lymphohistiocytosis, which I'm going to for now say HLH. But they have reported that, even though these are familial, these are usually autosomal recessive, these kids present very, very young. There have been reported cases of adolescents or adults getting primary form. The incidence is 1 in 50,000 live-born children, and it's a failed disease with a mean survival rate of less than 2 months after diagnosis if untreated. And some kids don't really have, even though it's familial, a family history because, again, it's fatal. So there's a mutation that happens that triggers it. Am I right so far?
Totally correct.
Now, the secondary form, this is the one that can develop as a result of strong immunologic activation of the immune system. And it can be a severe infection, viral, bacterial, parasitic, or secondary to certain viruses, like we said, EBV is known. We talked about malignancies or during the treatment of a malignancy. And then most patients with HLH are not obviously immunosuppressed. Doing well so far.
Yes.
Now, clinical presentation we're going to run through because we're already over an hour, surprisingly. Most typical findings are fever, hepatosplenomegaly, cytopenias. Other common findings they talk about include increased triglycerides, coagulopathy with hypofibrogenemia or low fibrinogen, liver dysfunction, elevated levels of ferritin and serum transaminases. And you can get neurologic symptoms like because of spinal fluid hyperproteinemia and a moderate pleocytosis. And again, the histopathology, these are widespread accumulation of lymphocytes in mature macrophages, sometimes with hemophagocytosis, especially affecting the spleen, lymph nodes, and the bone marrow, and the liver and CSF. They can get other abnormal lab findings, low natural killer cell activity, hypocytokinemia, and increased levels of IL-2 receptor. And infections associated with secondary HLH may resolve spontaneously, but they have an increased mortality. And then they go into the diagnosis of this. So the differential is huge for HLH. So malignancies, infection, rheumatologic disorders, EBV, viruses. So the differential is just basically everything that can cause a very sick child because these children are sick. And so then how do you diagnose it? They have the following criteria. So there's the molecular diagnosis consistent with HLH, which I read that section out there 3 or 4 times. I did not understand it. I'm not going to sugarcoat it. So I just left it as is, molecular diagnosis. So that's when I would call you and you would help me.
So, geneticists sometimes are helpful. And then some institutions, hematology, oncology do it because the protocol for treating like a primary HLH is going to involve chemotherapies and even bone marrow transplantation. So like at our institution, if we think your primary HLH, hematology, oncology is the team that will manage it. If you think it's more MAS, then rheumatology will manage it. And then if it's because it's not proven to be primary, but because of infection, then it depends. It's probably multidisciplinary. Okay.
And so then you need 5 out of the 8 diagnostic criteria. So in the 8 diagnostic criteria, fever, splenomegaly, cytopenias, which are affecting 2 of the 3 cell lines, so platelets less than 100, neutrophils less than 1/10 to the 9 per liter, hypertriglyceridemia and hyperfibrogenemia, hemophagocytic and bone marrow, spleen, lymph nodes, hemophagocytosis, low or absent natural killer cell activity, ferritin greater than or equal to 500 nanograms per liter, and soluble CD25. Now, if I remember correctly, these ferritins are really high, HLH.
They tend to be. So the greater than 500 is helpful, but they can be 60,000, 100,000. So they're going to be very high. The things like the soluble CD25 and the NK cell activity, they're great and they help, but they take a long time because they have to go to specialty labs. So they're often not going to be there when you're really initially trying to diagnose someone. So most of the time people are looking at those other markers.
And so it's a life-threatening disorder. And you said treatment is immunosuppress, allogeneic hematopoietic stem cell transplantation, and then that's very effective in kids. Is that right?
Yes, if you have the primary genetically based HLH.
And poor adults have poor outcomes with that. Mm-hmm. And then etoposide is something they talked about. Mm-hmm. But I didn't find mortality. I know it's high. I don't know what the mortality rate of this is. Looking at the literature.
Mm-hmm. I think it's hard because it depends on primary or secondary. Depends child. And I think over time things will be different because, again, it is still missed sometimes, but it's recognized much more commonly. And we do have a lot of treatments in our arsenal, including biologics. Yeah, so there are newer biologics that reduce morbidity and mortality. There's ruxolitinib, which is Janase kinase inhibitor. It's now FDA approved for primary HLH. And there's emapalumab, which is an anti-interferon gamma antibody.
Now, this seems to me like these kids are going to be in the PICU, not so much with us. Now, they may start out with us on a hospitalist team and then get very ill and be transferred. So I guess it's good to know for us that they're reviewing HLH and MAS, knowing what to look for. We know what battery of tests to think about. And then if we're thinking that's what this is, to get help involved, because you're going to need to be in an ICU setting, either a hematologist, oncologist, or a rheumatologist, depending upon where you are. Mm-hmm. So if you're in a community hospital and you think that this is going in that direction, that's a child you may transfer to a facility that has a pediatric intensive care unit and maybe those subspecialists at hand. Versus if you're in a setting here where we are, I would know I'm going to get people involved early. I'm going to send the proper testing. I may transfer this child to the ICU. But it's nice that we reviewed them.
Yes, that's correct. Because these, again, can be, it sounds really concrete in the paper, but they can have a huge spectrum of what you see.
And so just at least having that in the back of your mind as a potential very serious diagnosis, at least it'll flare your antenna up maybe a little bit sooner.
Yes, because the earlier you think about it, the earlier you'll recognize and can intervene.
Well, that was great. I mean, I don't think we can cover more. We're over an hour in. We'll do lupus another time as long as you don't mind coming back to do this again.
Sounds perfect.
I really appreciate your time, Elaine. Thank you very much for helping out with this. I really enjoyed it. I thought it was a great discussion.
I think the jokes were the highlight. Thank you for having me.
Well, so let me wrap up, everyone. This is thank you all for listening again. My name is Tony Tarchichi. I'd like to thank for our acknowledgments, of course, our guest, Dr. Elaine Cassidy. Thank you very much, Elaine. I would also like to thank the Children's Hospital, UPMC Children's Hospital Pittsburgh, for letting me continue to do this in my division, the Paul C. Gaffney Division of Pediatric Hospital Medicine, for supporting me with this. I'd also like to thank, as always, Dr. Megan Keene Tarchichi, who helps me with everything. Thank you to all those who are listening. Please remember, there's free CME associated. Just click the link at the bottom. And as always, if you have any suggestions, concern, compliments, or worries, I'm happy to take them. And please remember, if you're listening, the AAP section on hospital medicine executive committee has a vote. Please make sure to vote. You should get an email if you're a member. Thank you all again, and I will see you at PHM. We have some exciting things we're going to do for the PHM conference this year. Again, we changed our name. This is PHM from Pittsburgh. If you have any suggestions or comments for a podcast, compliments, or anything, please feel free to email me at tony.tarchichi, tarchichi, @chp.edu. We'll see you next time. Thank you.